At 9 young years, she left her home in Scotland and began life anew in the U.S. She lost her brogue and listened to an inner voice calling her to healthcare. But three Scottish traits never left her. Brave, stubborn, and bold, she ditched the old system. My guest this week received her MD from Baylor College of Medicine. She did her residency training at Providence Hospital in Washington, D.C. In January of this year, she started her direct primary care practice, Vida Family Medicine in Houston, Texas. She's known for providing fourth trimester care. Never heard of it? Me either. Have someone hold your beer and learn something new. Starting right now. Welcome to the show, Dr. Rebecca Berens.
Thank you. Thanks so much for having me.
Well, it's a pleasure. I have to ask a question. I went on Google, as a lot of people do, and I saw Vida Family Medicine is located at, I wrote it down, 721 East 14th Street in Houston, Texas. And from Street View, it shows a home.
Yes. Yes. It's a converted home. So I'm in an area of Houston called the Heights, which is kind of a historic part of Houston. And there's a lot of the older homes there that have been converted into businesses.
That's really putting the family into family care.
Yeah, it's really nice because when you walk in, you don't feel like you're in a sterile clinic. You're in a living room, basically, and it's a really nice living room set up in a waiting area. There's several other female-owned businesses there. The house is owned by a chiropractor, and she has her sister is also in there. She's an educator, so we all sort of share the space, and it's really nice. It's like a family environment.
Terrific. Well, you've been there since January, right? You started in January.
That's correct.
Okay. Well, one of the things that caught my eye, and I wanted to dive into it because it hit me as that's new to me anyway, and that was fourth trimester care. And you wrote on your website, you said, I believe high quality fourth trimester care can make a huge difference in helping children and families succeed. And when I heard fourth trimester, I thought, there's a lot more to that than meets the eye. Sort of implies that the baby's still in the womb, and not that I blame them for not wanting to get out, because when they do come out, they're like, hello, world. What's that about? I mean, what should people know about fourth trimester care?
Yeah, so the fourth trimester is really, that first 3-month period after a baby is born. And the mom and the baby's physiology is actually very tied together still at that point. Mm-hmm. The initiation of breastfeeding and that physiology in the woman is uniquely tied to the physiology of the baby. And they really, still need each other just as much as they did during when the baby was in utero. So it's a very closely tied period for both mom and baby. And, in a lot of cultures, women stay basically in bed with the baby for that whole period and rest and recover from the delivery and care for the baby. And they're not expected to return to their duty. Obviously, culture, there's women going back to work sometimes as early as 2 weeks postpartum, which is really stressful.
Yeah.
And so we're not really optimally caring for women during that period currently.
And as part of that, I had Dr. Molly Rutherford on the show not that long ago, and she is direct primary care, and she's also an addiction specialist. Mm-hmm. So it was interesting that the dots were connected, that because she is DPC, direct primary care, it really enables her addiction recovery practice to do more. Right. So it seems to me that direct primary care is sort of a force multiplier for you in fourth trimester care. How do you find that since starting in January?
Yeah, absolutely. It's so different than how we traditionally care for before and postpartum. The way that we currently do things, baby has to go in several times to the office, usually 2 to 3 days after birth, and then maybe again at 2 weeks, and then again at 1 month, and then at 2 months. That's a lot of trips to the doctor for a baby, but I mean they're all necessary. We need to check in on the baby's growth and their development, and their make sure they're feeding adequately. But it's a lot of trips for a mom who's postpartum and possibly recovering from major surgery if she had a C-section. So that's stressful. But then the mom, often we don't check in with her until about 6 weeks postpartum, and then that. And there's a lot that's ignored about the mom postpartum currently in our healthcare system. And some of that is starting to be addressed by the traditional healthcare system. But the way that traditional payment works is you get paid for that one postpartum visit. And if you do other checks, that's not going to be covered in that global delivery and prenatal care fee. So it's not really covered. And we know that postpartum depression is so common. Breastfeeding difficulties are so common. And there is really no place in the traditional medical system for that. So a lot of women end up seeking out help from, maybe a postpartum doula, a lactation consultant, other professionals. But it's all very disconnected from their physician. So having one person who cares for both you and your baby postpartum, like I said, the physiology is tied. So it's important to have all of that care sort of being managed by one person. I think it's the best way to make sure that nothing's missed and everything gets addressed.
It would surprise me if that could be done very effectively in the old system. How does that work?
Yeah. So personally, after I had my baby, I took him to all these pediatrician appointments, and I had my little postpartum visit, but my visit couldn't have been more than 5 minutes long. So there was really not much addressed. And I'm aware, obviously, I can advocate for myself. I know the things to look out for, but it was a lot of stress on me as a new mom who's sleep deprived and stressed out, to have to also kind of be in control of asking for help when really we know that these issues are common. We should be able to reach out to women and be more proactive rather than reactive.
Yeah. So DPC really enables you to do a much better job than the old system. And do you have patients that have come in who were in the old system and now they're in your system, and they're comparing and contrasting what they had versus, wow, this last baby is a lot easier or better?
Yeah. I mean, I've had a lot more of actually first time moms who I think recognize the stress that is going to be coming up, and they're looking for that support, and they're seeing that they're not going to get it the way that they're hoping for in the traditional system. But I'm sure, for like myself, looking after the experience that I had, if I were to have someone that I could have just texted a quick question at any point when I was in the middle of the day by myself at home with this baby and they're screaming and I don't know what to do, having someone you can reach out to is so much easier than Googling and goodness knows what you're going to find when you Google. It's actually crazy. The social media marketing that is targeted at postpartum moms, all kinds of products and online courses sold by dubious people with no credentials. But I mean, you buy into it because in that moment you're so desperate. So having some more legitimate options of resources that are available to you would make such a huge difference.
Yeah. Well, I guess it's people aren't used to comprehensive primary care. They don't know what it is. Right. And it's been so long since, we used to have it, when I was a young kid, 60, well, I'm 60. So, back in the 60s when it was still around, I had a family doctor who knew me, knew my family. And so the comprehensiveness, I think, is what surprises people the most.
Yeah. People serve by design, the system is designed to create separation because they want the doctors in the room seeing as many patients, and they're like, we'll take care of the rest. But that's a barrier. The patient can't reach the doctor. So they're reaching, maybe have someone at the front desk, and they look at the schedule and they say, oh, well, our next appointment's in 2 weeks. They don't understand this is a potentially urgent issue that needs to be seen right now. So to take those barriers away and just connect the doctor to the patient really allows you to be more flexible and adapt to the situation rather than forcing the family to adapt to your system.
Yeah. How do you describe, when someone first walks through the door, how are you describing it? How are they walking in the door fairly well briefed, or do you find yourself doing a lot of education?
I think a lot of the education comes before they ever show up. Because a lot of people will go to the website and they'll read about it, or they'll maybe see, I'm on social media, so they'll maybe see me on social media and they'll have maybe some idea. But it's a lot more education usually over the phone or through email when they first reach out to me. When I kind of explain how it works and the services that are available, and yeah, it's completely different than anything that they've experienced usually in any other medical professional's office. So there is a lot of upfront education, I think.
So that you're blessed with they're fairly knowledgeable walking through the door.
By the time I see them, yes, but to be honest, they don't usually walk through the door. I usually do the first few visits at their home, just because that early period it's so stressful to get a new baby and yourself out the door into public. So I usually go to their home for the first few, those early visits, because that's really when it's harder for the mom to get up and about, and it's much easier for me to assess the full family situation when I go to their home and I kind of see how things are doing. You learn a lot from being in someone's home versus how they are in your office.
In my notes, I have that point to make, because you just, how surprised are they when you knock on the door and go, hi, I'm here? I mean, I know they're not surprised, they're expecting you, but that's got to be just, they're on social media going, you're not going to believe this, the doctor came to my house.
Yeah, and it's interesting because people are used to other professionals coming to their home. They're used to home health nurses, they're used to lactation consultants, they're used to postpartum doulas. All those people will come to your home. So that's not groundbreaking. But most people are like, wait, you're really a doctor? Because I've never had a doctor come to my house before. And it's so unheard of nowadays to have a doctor actually show up to your house. Everyone assumes I'm a nurse.
Wow. You don't wear the white coat when you visit?
I don't know.
No, I think you need a bigger name badge.
That's kind of gross.
Hi, I'm Doctor. Hi, I'm Doctor. And then, well, anyway.
No, I should get myself some embroidered scrubs or something, but I don't know. I don't like the white coat. It's just extra.
Oh, I don't, as soon as they, I think people are going to be comfortable in their own home, and they know you're coming and they know you're a doctor, but still it is unusual, as we know. So I wrote it down here. You got your MD from Baylor College of Medicine, and then you went to residency training for family medicine at Providence Hospital in Washington, D.C. And this is all fairly recent, within the last, 10, 15 years, right?
Yeah, I graduated from medical school in 2013. So it's been 7 years since I graduated. So
what drew you to family medicine? Because recently, in the last 10, 15 years, maybe even 20, more doctors coming out of medical school are choosing a specialty rather than family medicine. And there's a tough time getting more. We need far more family medicine doctors. What was it about family medicine? And I have a hunch, but I'd love to hear I'd love to hear reality.
Sure. Yeah. So when I applied to medical school, I was planning to go into oncology. And the reason I even applied was I was interested in cancer research and cancer just because we had a lot of cancer in my family. And I lost my grandmother when she was really young to cancer. So that was always in my head that's what I was going to do. But, as I was applying, I thought maybe I should actually shadow a doctor before I show up to med school and know what I'm getting myself into. So I actually went and shadowed a family doctor that was local to me in a federally qualified health center. Is where I got my shots when I was a kid. And I just asked him, I was like, hey, can I shadow you? I'm applying to med school. I want to make sure I know what I'm getting into. And he was a family doctor, and he's one of the old school family doctors that's cradle to grave. He did prenatal care. He did deliveries. He did a lot of women's health, colposcopy, different women's health procedures, and cared for kids all the way through geriatric population. So I shadowed him just a few times, and I just got such a sense of, you really can take care of the whole person and the whole family. And that is so much more important for prevention.
Sure.
By the time you're an oncologist, it's a lot of times, you're helping someone through a difficult time, but it's kind of too late. The cancer's already happened. So being on the preventive side, you can prevent a lot of health problems if you start with the family and with the whole person rather than focusing on that one disease. And so I just really loved that. And as soon as I entered medical school, that's what I decided I was going to do.
Wow. Well, I think right around the time you were getting into it, back in 2008, genome testing was about $75,000, $80,000. And now it's about 200. So it's now in your space. So I have a feeling that family medicine, primary care is going to attract more doctors because you are doing more Sherlock Holmes kind of thing. I don't want to really say house, but the point, I'm not a doctor, but I grew up with a father who taught creative problem solving. So connecting dots, boy, I would be, if I were going into medicine, I don't think there's a better place to go for putting your Sherlock Holmes hat on and having at it than primary care, because that's where you're seeing the whole patient. And something you alluded to earlier, and that was going into the home and seeing the environment in which people live, work, and play. That's a huge deal. It's been missing for so long. Yeah, and that you're able to do it.
It has such an impact on health too. We know that, and yet it's such a little part of what we do in the office.
Yeah. And are you still an assistant professor at Baylor College of Medicine?
I am, yes. I work part-time there. So before I opened my own practice, I was working there with the family medicine residency, and I was teaching residents. And so I still work there part-time and do a few shifts a month. Yeah.
So how do you find the students? Are they getting more? Are they more motivated? I mean, are they seeing kind of the same thing that you did? The family medicine. I know they're in family medicine if they're there, but how are they seeing things right now?
It's I think the interest in family medicine is definitely growing. It seems to be more so than when I was a student at Baylor. But the Baylor students are just incredible. They're all so intelligent and so hardworking and really motivated. And even the ones that aren't going into family medicine, when they come, they work really hard and they want to learn and they want to understand, what it is that the family doctor does. Because even if they're going into some hyper specialized surgery field, at the end of the day, they're still going to be communicating with family doctors. So they've all been great and very interested to learn about what it is that we do.
Well, you've got two expertise, which is women's health and breastfeeding medicine, as something that you specialize in, along with the fourth trimester. How much have those things changed, especially in terms of women's health and breastfeeding? How much have those changed since you've been as a perhaps a resident, now as a independent physician? Has there been a lot of change? I mean, how are you keeping up with that?
So I was always interested in women's health from the very beginning, and I in my residency I was the obstetric scholar, so I did additional work on the labor and delivery floor to get more experience with deliveries and obstetric care, postpartum care. So that was something I was always interested in. the breastfeeding side, it has really been more recent. I was always interested in it, but I didn't know that much about it. We learn a little bit, but we don't learn how to troubleshoot. We don't learn as much of the physiology and the problems that can come up with breastfeeding. And so it wasn't actually till I had my son that I realized how little I knew. And I was like, I need to learn more about this because it is such a gap for women to not be able to get that kind of care from their doctor, and they're having to seek out other professionals, which are great. But if there's something minor that I can fix for them, I would love to be able to include that in their care. So I actually went and got some additional training through the Lactation Education Resources, which is an organization that does training for lactation consultants. And I sought out some additional trainings. So I ended up doing 90 hours of their lactation consultant course, basically, in addition to my kind of just in between patients or after work on weekends, tried to fill that in so I would learn some more about that. And that was just something that, we kind of glossed over in our training. We learned the very, very basics, but not a lot.
You said something there when your son was born. My dad used to say, "Son, you didn't come with an owner's manual."
No, they really don't.
and I have a feeling mine would have been about that thick.
Yeah, well, us doctors are lulled into this false sense of security that we kind of know what we're doing because we learned about newborns and we learned about how to treat children who are sick. And so you think, oh, if I can handle them when they're really sick, surely I can handle them when they're well. No.
Yeah, well,
completely different ballgame.
I mean, if it was tough for you as a doctor, I can't imagine what it would be like as a normal woman who's having a kid, let alone men. I mean, my goodness, if men were having babies, we'd have been extinct a long time ago. So I can't even think about that. And I think it's important to note that you also treat men. And that goes back to what you see in the home, because it's not just treating men, it's also that educational component. Like, okay, for the next month or two, your wife is going to be experiencing this. Therefore, you need to do some of the laundry. You need to do whatever. And also time for her to rest, kind of thing. So it gives you the opportunity to do more education. That's got to be very helpful to both mother and father.
It is. And, men really want to be involved, but there's been this sort of cultural exclusion of them from, the postpartum period for years. They used to be in the waiting room. They used to not even be in the delivery room.
Right.
And it's not because they don't care or they don't want to help. They just have literally been excluded, and no one ever teaches them anything or tells them anything. Half the time they're sitting in the appointments and the doctor doesn't even look at them. So you really have to include the men in the conversation, because it's a family unit, and it's not just the mom and just the baby. It's the dad is just as important. And when you are able to bring them in and explain, this is what she's experiencing, this is what you can do. They always are extremely happy to help and on board, and it's they've just been excluded and they didn't know what to do before.
Yeah. Well, it's so sad for so many, for up until recently, until men were invited into the delivery room, they really were just sort of excluded from the whole process, as you said. And now I think their role changing as being more, not motherly, but being more involved in the care, mm-hmm. and taking the time. But I think something for everyone to learn is when you have direct primary care, when you have a direct primary care physician, probably the single most important element of this is the fact that you have more time to spend with mom, dad, kids, perspective. And it takes time for you to connect the dots, to look at the testing, to look at genetic testing coming up, diet, exercise, what's going on, plus plus plus. There's so much more for you as a physician. In the old system, it doesn't work. It just doesn't work.
Yeah,
So
if you take 5 or 10 minutes, you can only address hit the check boxes, whatever it is you have to check off for the insurance to pay you for the visit. You don't have time to really delve into the family dynamics and the health status of everyone and the employment status of everyone, the financial situation for the family, the extended family support, and really understand the whole dynamic.
Yeah. Dr. Rebecca Berens with me today. COVID-19. We're in the midst of this worldwide pandemic. And so I would suspect that your patients who have access with direct primary care, not much has changed in terms of their access to you. It's the people that don't have it are saying to themselves, how come I've never had this access before? Because telemedicine's been enabled for them. But for direct primary care patients, having that access with you is nothing new. That's great. How are they dealing with it?
So for my patients, it's been kind of business as usual. They always were able to text me to get a hold of me. The only change I've really made is I'm not doing any in-person visits unless it's 100% necessary. And then if it is necessary for me to see them in person, I'm going to their home rather than having them come to my office, just because I don't have, hospital equipment to sanitize everything after someone's been in my office. I'm in a house after all. So I've just been going to their home to limit the exposures and limit their need to come out into the world. So that's really been the only difference. I've had a few new patients sign on since the pandemic started, and I typically would always see someone in person first before, before continuing on with telemedicine with them. But I'm just kind of delaying that for now and onboarding them with a telemedicine visit and or a home visit if it's necessary.
What surprises them the most about when they become a patient a month or so in? What's like, gosh, what surprises them the most?
I think it's always seems to be confusing to them that they can text me. And maybe this is me. I'm a millennial. So I've been texting since I was in high school. But but most people text. That's how most people communicate now. And I think it's I give them the app to download so that they can securely text me. And at first they're like, wait, really? So I just text you, and then. But now, I'm able to handle a lot of things just via text message. And then if it's something where I need more information, then we just convert it quickly to a phone call or a video chat. And then, something that previously might have been phone tag with the office for 3-4 days is now handled in 5 minutes.
That's access. Timely access is so important. And once you have it, you'll never go back.
Right.
I have it. Direct primary care is the way to go. But, so what was the first day like when you opened up? It was Showtime, Hollywood. Did you have any patients coming with you? How did that work?
I had no patients coming with me.
None.
None, no. So because I was working with the medical school before, I was working at a county health clinic that the med school works with. And so most of those patients are indigent. They either are on Medicaid or don't have access to Medicaid. And a lot of them can't really afford medical care. To be honest, a lot of them probably could end up affording direct primary care. It's pretty affordable, but, most of them are disenfranchised in some way, whether it's a language barrier or socioeconomic status, immigration status. So I've had a few patients actually from there who have expressed interest since they learned about what I was doing. But it's difficult to go from free to paying, I think.
The value is kind of hard to,
it's different.
Yeah, if they're in that system, they have to get out of that system, so to speak, and then get into the direct primary care. So I'm curious about you. You grew up in Scotland.
Yeah.
How long were you in Scotland for?
I moved to the U.S. when I was 9.5.
9.5. Whereabouts in Scotland?
In Aberdeen.
Aberdeen. Ah, okay. Okay. And so it's kind of a circuitous route from Scotland to Texas to DC, back to Texas. And then now you're doing your direct primary care practice. What was it like moving at 9.5 from Scotland? How did that work?
It was a rough transition. It was a culture shock for sure. It was very, very different than what I was used to. And, I had an accent and I got made fun of a lot for my accent. So it was a tough couple years until I kind of adjusted and quickly changed my accent to fit in. But it was always going to be temporary. So I think that was the hard thing too. When we first moved, we were told it would maybe be 2 to 3 years. So it took me a while to even decide to settle in because I wasn't planning on to be here for the long term. So, once we kind of realized it was going to be more permanent, then you start to put down roots and settle in. But when you think it's only going to be a couple years, you're kind of like, what's the point?
Yeah.
So yeah, it was rough. It was a rough time.
I think when you were here, I think one of the biggest issues you probably had was Jackie Stewart was still doing Indy 500 calling the races for the Indy 500, and Jackie had that Scottish brogue going on.
Well, I only heard about the Spice Girls. That was all I heard about.
Spice Girls. First of all, I think it's worth a congratulations. I'm kind of still reeling from the fact that you started from 0 patients. That is good for you. I think that's the entrepreneurial spirit, number one. And I hope other doctors who are looking at making the switch can take have a little confidence boost from the fact that you made the plunge.
Yeah. I mean, I had so much support from other direct primary care doctors, and I thought about it for a long time. It was something I had heard of in residency, but in residency, I never thought I would be opening my own practice. My plan was always to work in a federally qualified health center or a county clinic. And I worked for 2 years after residency in a health center in Philadelphia before we moved back here. And it never even occurred to me to open my own practice. I just thought direct primary care sounds really cool, but I don't think I could do that. But it just became more and more clear to me that for my family and work-life balance, it was not going to work doing the traditional route anymore. And I just had so much support from other DPC doctors. So it's still hard. I'm not going to say that it's been an easy switch, but having all of those doctors around the country as a support system to, bounce ideas off of and give you support when you're having a bad day or say, well, this is what worked for me. You could try this. It's just been great.
Well, congratulations, because it's entrepreneurialism is not easy. It isn't. It's so worthwhile though. And I think the support that you're getting from within the community, the direct primary care community, is something that a lot of other doctors ought to know about, because you all love what you do. Mm-hmm. Who doesn't want a doctor that loves what they, do you really want a net negative as a doctor? No. Right. How about someone who's awake, aware, and alive with a positive attitude and gets up in the morning going, can't wait to get into work.
There's nowhere else in medicine where there's this level of support either. I mean, it's, all through med school, it's sort of competitive because everyone's trying to, get a good score on their USMLE, and they're trying to get into the best residency. And in residency, they're trying to compete for chief resident. It's competition the whole way through. So this is, there's no other community like this in medicine.
Yeah, boy, that's good to hear. It really is good to hear. So Vida Family Medicine, and I'm going to give the contact information. It's 713-766-4496. That's the phone number, 713-766-4496. And the website is vidafamilydpc.com, Vida, V-I-D-A, familydpc.com. Dr. Rebecca Berens, thanks for joining me today.
Thank you so much for having me. This has been really great. And, I would be more than happy to answer any questions anyone has or talk more about my practice and the journey of switching to a practice like this from zero. I'm more than happy to help anyone.
Well, I'll have the information in the show's description, and thank you all for tuning in. And until next week, there you are.